Can you see my slide in presentation mode? Thank you. Well, it's a great honor for me being here, and I thank the organizers to give the opportunity to talk here about echocardiography assessment on patients on VA ECMO. First of all, I would like to give you a slide overview. We have seen this already. VA ECMO is kind of a bridge to recovery or to transplant or to durable mechanical circulatory support. And it's a bridge to decision as well. And we have several indications why we use VA ECMO in clinical practice. And that's mostly cardiogenic shock after acute myocardial infarction, as the previous speakers told us before. So I will skip this slide again. And this we've seen again also already, but it's very important that when we do echocardiography that we know what is happening there and why we do echocardiography. There's a problem in VA ECMO because VA ECMO does increase LV afterload, and there are some strategies which are used by intensivists to fight the increase of LV afterload. We can increase the forward flow with inotropes or impeller or intra-aortic balloon pump. We can decrease the LV afterload by intra-aortic balloon pump. We can do some crazy stuff as mechanical decompression with arterial septostomy by the surgeon, or implant impeller, transeptal cannulation of the LV or LA, which are pretty invasive maneuvers, or direct surgical LV apical drainage. Or something what we're doing in intensive medicine is removal of fluid from intravascular space by direct agents or ultrafiltration. As well, we can do some reduction in ECMO speed, which will reduce ECMO flow, but often it's not very well tolerated by our patients. So echocardiography, I will give you a quick overview about guiding in VA ECMO implantation, echo while on VA ECMO, how important it is, and some hints on weaning. And when time is enough, when I have some time left, I will show you a successful case of a patient in cardiogenic shock who was on VA ECMO in our ICU. First, in guiding, for guiding, we use usually transesophageal echocardiography, but often it's very difficult because the room where we're in is crowded with healthcare workers. We have ICU nurse, ICU medics, ECMO technician, perfusionist, and it's me with my big machine. So the room is very overloaded with personnel and stuff. And sometimes it's not very comfortable to intubate our patients. So just ask for help with the ECMO handle, which will facilitate the intubation with the TU probe. The patient is not in the comfortable position. And we do guiding during CPR with a very stressful situation, or also during not CPR, but it's an emergency. So we are kind of stressed when we do guiding in VA ECMO. The guiding is done by TOE, but it's also possible with transthoracic or with fluoroscopy. But before we do our guiding, just take your time and have a look at the heart and look what's the problem there. If there's aortic regurgitation, if there's ASD, if there's aortic dissection, which would be a contraindication for the implantation of VA ECMO. If there are lots of arteriosclerosis, which maybe you have to change your goal from peripheral to central, or better ask the surgeon to do a surgical approach. The complete exam is often not possible because we are in a critical situation. So there's always just the assessment of anatomical aspects and exclusion of reversible causes, tamponade, for example. As in every interventional echocardiography, there's always time, it's kind of that time where the intensivist is looking for the groin, is looking for the needles to look. So you can use this time to do a quick overview of the heart. What's my approach there? At first, I go with deep gastric and look for the LV and RV. Then I took mid-esophageal 4, 2, and 3 chamber view with color to look if there's heart valve disease, how is the ventricle left and right is doing. I look at the bicaval view and of course at the aorta. But I'm always aware when the intensivist is calling for help, I will stop looking and give him some help. So, but before we start VA ECMO, that's often done just before. We have lots of parameters in echocardiography where we have to look. I will just skip in order to time this slide here. When we do guiding for VA ECMO, we guide the wire location in the aorta and the bicaval view, and it's kind of teamwork. We have to talk to our intensivist and ask him what he wants to see. There's the word color reflex. I will show you an example. What does it mean? Then we look for the positioning of the cannula. And of course, we look at exclusion of implantation-related complications as dissection, tamponade, and thrombus. And as well, we will give some pretty important information on the right ventricle, as my previous speaker focused on before. And of course, we have to look for RV lead, prominent Chiari network, which maybe can be a problem while positioning the wire, as well as TV or tricuspid prosthesis can be a problem. When we look for the wire in the SVC, we make sure that the wire is not finishing in the right atrial appendage, or is not going the wrong way via PFO to the left atrium, or is finishing in the right ventricle or to the coronary sinus. And we have also have a look if there's any tamponade coming or not. Here's some images from the wire coming from the SVC on the left panel, upper panel, and from the right lower panel coming from the other side. That's what we see when we do it by bicaval view. And what I told you before, the color reflex, sometimes it's kind of difficult to identify the wire in the bicaval view. And what I learned in interventional echocardiography doing lots of mitral clip procedures, the color reflex on the wire can help you to identify the wire. That's very important for your intensivist to show him the wire, because over the wire he will come with the cannula. Here's the example where the wire went the wrong way. It's in the right ventricle, and that's not where we want to have the wire, of course. Once the wire is positioned, we go with the cannula, and the cannula went up from IVC to just the bottom of the SVC. And as we can see here very nicely, it's an artifact from the cannula. It's not two canisters, one. You see it here. It's a very nice picture, I guess. And here the cannula is coming from the other side. It's from the central approach. From the OR done. And here's an example of what we don't want to see. It's when the cannula is going the wrong direction. It's kind of pointing versus the PFO. So that's a point where you have to stop your intensivist pushing the cannula. So on the right panel, we see that the cannula goes the right direction. And here's what can happen when you have a problem with your probe, the cannula going to the left ventricle, left atrium, can have a thrombus formation, which is also very important to tell your intensivist that you have such a complication here. Next up, when you have positioned your cannula in the venous system, you will proceed with the wire for the aorta. And what you see here is a biplane view of the aorta, and there's something there which is here. It could be a dissection, but as we looked before the patient, before we started, I identified that it was an impeller there, so I could calm down my intensivist and telling him that's not a complication, but it was the impeller which was in the aorta as well. And that is the images where the wire is passing through the aorta. And here's an example where the ECMO cannula is with the ILBP in the aorta descendants. and that would be one of the complications we do not want to see during implantation of VA ECMO, dissection of the aorta descendens. This is an example on the left side. Before we placed the ECMO, you see severely dysfunctioning left ventricle. It's cardiogenic shock. And on the right side, the ECMO is placed and is working. And that's what I look for. I look if there's a pericardial effusion or if there's any LV or RV thrombi in the ventricle before we stop guiding and looking for the heart. That's for what's regarding the guiding mechanism. And during ECMO, we go to the patient on the ICU and do some echo. And this is here a very nice table where we can what we can look at when we do our exams in ICU on patients who are on VA ECMO. One of the most important things is we have to look at mitral and aortic regurgitation if there are some, so we can identify them and look what we can do there. Another very, very important issue is the opening of the aortic valve. Here I have a recent case we had from a patient with cardiogenic shock, and you see at the beginning the therapy, the patient has no valve opening, which is high risk for thrombus formation. After a couple of hours, the arterial line was a little bit better, small opening, and some hours later in the evening there was more movement in the arterial line. So that is what we have to look as well when we go to our patients in ICU during our echo. Just have a look on the monitor, which is very, very helpful. Then, of course, we look at spontaneous contrast or thrombi in the left ventricle or right ventricle. Here, example of a patient with left ventricular thrombi, things you do not want to see, or in this case, which is very unfortunate, yes, thrombi in the right and the left ventricle. We have to remember that these are very, very sick patients, and it's often very difficult to monitor them and to continue therapy with them. So after guiding and echo while on VA ECMO, one other important thing why we get called on the ICU is the weaning process. Someday we have to wean our patients from the VA ECMO. And this is a very, very nice paper which gives us some hints on how to wean a patient from veno-atrial ECMO. And that what we look as echocardiographers is once we have the clinical clearance, is there's our parameters we look at is LV function, aortic VTI, and the TDI of the lateral mitral annulus. So how we do the weaning echo, usually we use transthoracic echocardiography, but I'm aware of when the image quality in the window is not good, we have to use TOE, but we have to be aware TOE is invasive. Patients have the risk of bleeding. Often we need sedation, so that will reduce the hemodynamic situation of the patient. So that's kind of difficult. When we look at the weaning echo, it's a team effort. The intensivists have to give me the clearance. We have to have a map over 70 over 60 millimeters mercury without with a reduced dose of inotropics or device support. We have to have a good oxygen saturation greater than 95%. Central venous oxygen has to be greater than 70%. And we need to have normal ventilation and an improving chest X-ray. And of course, echocardiographic data is very important. LV function above 25 or 30% is very helpful. So our weaning helpers are LV function above 25, 30%, aortic VTI greater equal as 10 centimeters, and TDI lateral mitral annulus peak systolic velocity above 6 centimeters per second. Is there any space for RV function? Yes. There's a study which showed 3D right ventricular ejection fraction above 24.6, which is a very precise number, I guess, was associated with higher weaning success and lower 30-day mortality in patients receiving VA ECMO. It's very interesting. We look at our LV function, and I try to look at RV function as well, but it's not so easy in the routine echo, I think. That's our Weaning trial we have at the German Heart Center, which is very similar. We reduce ECMO flow by 1.5 to 2 liters per minute in 2 days and look if everything comes out. We look at the inotropes, and then we look at the echo. If LV function is above 25 or 30%, and we have stable situations, then we proceed with explantation. Here's a Weaning trial we have done a couple of years ago. You see 3 echo views, 4, 2, and 3 chamber views, various amount of ECMO. Oh, sorry. By reducing the ECMO flow from 4 to 2 to 1 liter per minute, and the slide down, we have the S-max and the LVOT VTI, and as you can see clearly, the LV function did not stayed fine, and the VTI stayed fine as well. So after this, I just want to pursue in the last couple of minutes I have left a clinical case which was quite successful. We had recently this lady about in her late 60s. She came to us with cardiogenic shock by with left main problem and CTO of RCA. She was already with an impeller pump. So we proceeded with VA ECMO implantation. On the left side, you see the really depressed left ventricle function. On the right side, we see after the VA ECMO was implanted, no thrombi, no other problem there. So then 4 days later, we could already reduce the ECMO flow to 2 liters, but the impeller stayed high with P9. And as you can see, the LV function, although she had almost a CTO of left main and CTO of RCA and was got PCI, the left ventricle improved in 4 days in an incredible way. Still, she has lots of MR and aortic regurgitation as well, but maybe it's due to the impeller pump, so that's not clear for now. And the LV function, as you see here with the 3D, was measured by 41%. So then we could manage after 1 day again to reduce the impeller as well. So we have a P2 venting here. And as you can see, the LV function is still stable. It's about 40%. VTI of LVOT is 13, and the S-max is quite doing well as well. Then everything was explanted, and today when we did the explantation, she had a slight problem with rhythm. She was in AFib. After amiodarone, she was in cardiac arrest for 1 minute with CPR. That's the echo we did immediately after, and she was under inopressors again, but LV function is doing well. And unfortunately, I do not have any other images, but I can clearly tell you I have seen her yesterday on my duty walk rounds. She's doing quite well. She's almost extubated, and I guess she's doing very fine. So let's come to the end. My take-home messages is when we do guiding for VA ECMO, just do a quick assessment of infarct complications, look at LV and RV function of heart valve disease, if there's tamponade or PFO, and always have an eye on complications as aortic dissection, pericardial effusion, or thrombi. The wire often is hard to find, so you can use the color reflex to find it in the heart. It's very helpful, and I always find the wire with this color reflex. Weaning of VA ECMO is looking at the LV function. It should be above 24.5 or 30, the LVOT above 10 centimeters, S max above 6 centimeters. 3D RV function can be helpful. I would say above 25% is a good marker. And if MAP is falling around 10 to 15 millimeters mercury or below 65, the patient is not ready for weaning. That's another thing we have to take into account. And in my practice, TOE is almost guiding, TTE is almost for assessment, in where we have a good window. So I come to an end. Thank you for your kind attention, and I'm ready for your questions.